Hello, everyone. My name is Randi Wright, and I have with me today Amber Clements for. We're both DNP students at Arkansas State University, and today we're going to be providing a presentation on a performance budget, and it's going to be specifically for a rural health clinic. And so, as the presentation goes on, we'll kind of explain what a performance budget is and what that entails, and then what a rural health clinic is and what the regulations and things like that are for it as well. We'll identify some performance areas that we're going to discuss and also some measurement tools that we can use for that, and some goals that we're going to kind of set for our clinic as well that will hopefully improve revenue and improve overall patient care. And so if y'all are ready, we're going to go ahead and get started with the rest of the presentation. Okay. So let's get started first with why a rural health clinic. The first reason we feel like a rural health clinic is needed is a lack of providers. There's a lack of primary care and specialists in rural health areas. It's a challenge to recruit providers due to lack of extracurricular activities for their families, schools, and shopping. There's also a lack of clinic and urgent care or emergency services in a rural health clinic, a rural health area. There's decreased transportation. Often these people in these areas are poverty-stricken with little or no transportation. We feel that doctorate-prepared nurses can fill this gap in care by providing comprehensive care at a lower rate than physicians in rural health clinics and allow nurse practitioners to practice without a physician present in the clinic. Nurse practitioners will have a collaborative agreement with these physicians in these clinics. So how to improve access to care? We feel that a rural health care clinic in north central Arkansas is needed. This clinic will be open Monday through Friday, 8:30 to 5 p.m. We will provide an after-hour telephone triage. We will employ 2 nurse practitioners to ensure access to providers and also for same-day appointments. We will offer immunizations. As we discussed on the previous slide, there is a lack of transportation. And lastly, we will provide management of chronic conditions and acute care needs, such as well child visits and cancer screenings. So we will begin first with our performance area, quality of care. Quality measures are a direct result of evidence-based care that promote health. The National Quality Measures Clearinghouse provides information on 16 measure sets. Each goal is measured at the 10th decile. Working with the $500,000 budget, $208,500 will be allocated for quality of care annually. This goal of performance area is to improve reimbursement from insurance companies to achieve a higher star rating. Meeting 14 to 16 of these quality measures will decrease overhead and supplies cost by 16% annually or 4% quarterly. This could result in a $13,031.25 savings per 1% decrease in supplies and overhead. So now we'll look at the measurement of quality care. These 16 quality measures result in a clinic rating on a 5-star rating scale, with 1 star being considered less than adequate and 5 stars indicating top performances. Each measurement will be totaled quarterly. There are benchmarks for prevention testing, such as mammograms and colon cancer screenings. Tobacco cessation is also measured in these benchmarks, as well as BMI treatment, hypertension control, diabetes control, and ischemic vascular disease treatment with aspirin and statin use.
Next, we will talk about performance areas with patient satisfaction. The goal of the performance area of patient satisfaction is to increase patient satisfaction and overall health outcomes. This will be measured through patient satisfaction surveys that consist of 3 open-ended questions that address satisfaction with treatment, follow-up, and recommendation for future visits. A 5% improvement in adherence to healthcare plans would be one measurement tool. Also, reaching and maintaining a 4 to 5 star quality rating, as previously discussed, would be another measurement tool. The annual cost of the performance activity to improve patient satisfaction would be $1,779,750 annually, with a projected $35,950 gain from every 1% improvement in adherence to the prescribed health plan. Next, we'll do measurement of patient satisfaction. Patient satisfaction measurement, as with surveys, is essential to the success of a clinic. Education is key regarding medication safety, appropriateness of ER visits, and importance of chronic care management and prevention. Involving patients in care can improve adherence to the treatment plan as they become an active participant in their care. Next, we will look at performance area with staff satisfaction. Staff satisfaction is another performance area that will be addressed in the performance budget. Staff satisfaction will be monitored by an annual survey. The goal of this area is to decrease staff turnover rate and increase overall satisfaction. By improving staff satisfaction, this will decrease absenteeism and increase productivity. The measurement tool in place is a 20% reduction in staff turnover. And the annual cost of the performance area is estimated to be at $111,750 annually, with a $5,587.50 saving per 1% reduction in turnover. Measurement of staff satisfaction. The staff satisfaction survey will be conducted annually and primarily use open-ended questions with a 5-point rating scale of 1 to 5, 5 being the greatest, 1 being the less satisfied. Leadership by the DNP prepared nurse practitioner is key to building an effective team. Monthly staff and services will be provided. Staff education is of great importance and empowers staff to engage in a learning culture that will create a better community and improve staff satisfaction. So now we'll begin with how we're going to design a rural health clinic. The rural health clinic will provide both scheduled and walk-in appointments, Monday through Friday, 8:30 to 5 p.m. This allows for same-day scheduling and decreases unnecessary ER visits. An after-hours phone triage line will be implemented with rotating call between 2 nurse practitioners. This will promote accessibility to healthcare provider and allow the patient to communicate with their provider and help the provider to discern whether the patient should go to the ER or if a patient can wait to the following day. Staff will consist of 2 nurse practitioners, 3 LPNs, 2 receptionists, and an office manager.
So our next slide is going to be a breakdown of the percentage allocation to performance areas. So this is where we actually start looking at the performance budget itself. And as you can see, a lot of it's broken down into the 3 different quality areas that we've chosen, which are quality of care, patient satisfaction, and staff satisfaction. And nurse practitioners will spend the majority of their time with quality of care, 40%. Office managers, they're going to spend most of their time dealing with patient and staff satisfaction. Clinical staff, obviously, are going to be dealing with the patients a little bit more. And then as far as education, supplies, and overhead goes, the majority of our budget is going to be allocated to the performance area of quality of care. And here in a minute, we're going to kind of break that down a little bit more into direct care and indirect care. And then we'll also look at the actual budget itself and how monetary values are going to play into this. So this next slide, like I said, it talks about actual direct care and indirect care. So I broke it down into actual staff. So like we said, we're going to have 2 nurse practitioners. The majority of their time is going to be spent with the patient, so 70% of the time. But then they're also going to have some indirect care. So that's going to be dealing with more of the behind-the-scenes things. Office managers obviously are dealing more with making sure the clinic's running the way that it's supposed to be. And so 80% of their time is going to be involved with indirect care rather than one-on-one with a patient. And then clinical staff, so that's like our nurses, our receptionists, they're going to spend most of their time dealing with actual patients. So that's going to be 80% of their allocated time and budget. And then 20% is going to be spent with indirect care for a total of 100% overall. Okay, so this is what I was talking about where you're going to break it down more into actual monetary values. So the nurse practitioners, we're giving them a salary of about $90,000 annually. So with 2 nurse practitioners, that's $180,000. We broke that down based on the percentages of how much of that actual total goes into each performance area. So most of their money is coming from the quality of care aspect versus the patient satisfaction and staff satisfaction. Whereas with the office manager, the majority of their salary is going to go more towards patient satisfaction and staff satisfaction. And $30,000 is a typical budget for an office manager in this area. And then as you go down all these other areas, clinical staff, education, supplies, and overhead, most of that is going to be in quality of care. So that's where a lot of that's going to be spent. Clinical staff a little bit more with patient satisfaction and staff satisfaction. So this is another allocation of the operating budget. So like I said, it shows that most of the direct care where nurse practitioners are going to spend most of their time, that's a lot of their salary. And then the office manager obviously has less patient interaction, more indirect care, and so most of their salary is going to be in that area. Clinical staff, the same way as we talked about with percentages, most of their salary is going to go towards actual direct patient care versus the indirect care. And the total of all the salaries together is going to be $380,000. And then that's broken down. So as you can see, most of our budget is going to actually be more towards direct care rather than indirect care. Okay, so this is kind of about the budget and the overhead of a rural health clinic. So the goal for patient visits is 200 to 250 visits weekly. So that's for both nurse practitioners. And then most visits will have an evaluation and management code of a 99213. So that's worth $120 a visit. If we have a more complex visit, then it would be a 99214, so it's $180. And then a nurse visit can be billed at a rate of $95, and it's a 99212. So they also have like new patient codes, and that would be, an example would be a 99203, and that's for a new patient, and you would get $160 for that. There's multiple payer sources, so we'll be having self-pay, Medicare, Medicaid, and then your private payers, so that's more of your private insurances. So the next slide is about the actual performance budget. And we've kind of already discussed this in our different measures and how we're going to measure each performance area. But I'll kind of break it down a little more. As we said, with quality of care, the activity we're going to do is review quarterly data sets. That's going to be measured through 16 quality measures measured at the 10th decile and achieving a 4 to 5 star status. We're going to hopefully decrease supplies and overhead by 4% quarterly. And then we've already kind of talked about the actual monetary values of each of those, but it's quite a bit. Patient satisfaction, we're going to do surveys, and we're hoping to improve patient outcomes and reach that 4 to 5 star rating. And then we'll see that through a 5% improvement in adherence to the health plan. And then with staff satisfaction, staff surveys, we want to decrease their turnover rate and increase job satisfaction. So we're hoping for a 20% decrease in staff turnover. So next, I'm going to talk about the actual DNP essentials. So the first one is scientific underpinnings for practice. This optimizes the principles of well-being and prevention and management of chronic diseases. We're able to recognize behavior modifications and adapt preventative services and management of chronic diseases. We apply the nursing process to facilitate changes in behavior modification, and we provide holistic care, which is an essential of being a nurse practitioner in general. How we kind of do this through our performance budget is patient satisfaction surveys represent incorporation of patients into their own health care, and that increases compliance with the prescribed treatment regimens that nurse practitioners provide to their patients. So that's how that is incorporated. The next essential that we incorporated is the DNP Essential 2, which is organizational and systems leadership for quality improvement and systems thinking. So what that means is, and how we use it, is use of care delivery approach to build policy to promote health in diverse patient populations, such as in a rural health setting. Worked with community leaders to adapt health practices for persons living in a rural underserved area, and then develop budget cost analysis to improve performance areas. And how we kind of feel like we incorporated that into our performance budget is through the performance budget itself. So using a performance budget incorporates all of those areas that are essential to improving quality within that system. And it takes a lot of organization to be able to do that too. So we also incorporated DNP Essential 4. So that's information systems technology and patient care technology for the improvement and transformation of healthcare. So as everyone knows, we use technology a ton. We're obviously using it now to help promote healthcare. And what this means is we use information systems and technologies like our medical records and report builders. We use information to recognize needs of our patient populations. We ensure data is utilized like it's supposed to be ethically and promotes improvement of patient care. And we provide leadership to ensure data is protected and used appropriately. So we included this in our performance budget by creating reports from data that we got directly from our EMR system. And that's how we evaluate our quality measure and benchmarks. So that's a big component of the quality of care performance area. So DNP Essential number 5 is also used, and this is healthcare policy for advocacy in healthcare. And the different components of it are analyzing health policies to improve quality of care, demonstrating leadership with the building healthcare policies, and then also implementation of improving access to care in rural underserved areas, which directly ties into what we're doing. And then serving as an advocate for patients, communities to ensure social justice and equality of care, no matter their socioeconomic status. So demonstrating the ability of a nurse practitioner to practice completely independent of physician oversight, such as in a rural health clinic, provides direct evidence that may be used to change current healthcare policy, which is a huge component of this performance budget, and that's really what we're trying to do with this. So then DNP essential number 6. This is interprofessional collaboration for improving patient and population health outcomes. And to do this, you have to use effective communication in the development of policy and procedures, ensure standard of care with the use of supporting scholarly literature, and display leadership of communication with lobbyists, policymakers to improve accessibility to care. How we incorporated this into our performance budget is by building an infrastructure of support with local specialists, which is vital to the success of the rural health clinic. We often have to have consultation with different specialists and different interprofessional groups as well, so physical therapists, occupational therapists, and then specialists in different areas. And the final essential that we're going to discuss is Essential 7. So this is clinical prevention and population health for improving the nation's health. And this incorporates analyzing data to improve patient outcomes and improving clinicians' performance and delivery of care, creating interventions to improve care based on a reporting system, and evaluating care delivery systems to improve policies and procedures. We incorporated this into our performance budget through showing that community-based nurse practitioners, especially those that are in a rural area, have to directly interact with community leaders and school officials to provide services. So this is especially like a big part of our vaccination program that we're going to offer. And then just in a rural community itself, it's a small area. You have to be able to communicate with your community leaders. So finally, our implications to practice. So through this performance budget, we're hoping to increase access to primary care services in a rural area, which is a huge component. And then the performance budgets allow for an indication of the quality of care expected in a planned budget. So through doing a performance budget, we're actually able to show that quality of care can be expanded. And then knowledge gained from a performance budget will facilitate organization growth. So not only do we want to grow our business, the rural health clinic, but also we want to help provide the best care possible to our community because it's where we live. And that's the biggest component of being a rural health clinic is it's not just about you, it's about your community too. So I think that's about the end of our presentation. We're going to provide all of our references here at the end, but that's the completion of our actual presentation. If you have any questions, please feel free to email us, and thank you for your time.